Okay, I think we'll kick off, and there's a few people still coming in, but they can join us when they're ready. So I'll just introduce myself to start with. My name's Paul Fisher. I'm a clinical psychologist, and I work here at JCU. Welcome to people who've not been here before. I work as a clinical psychologist, but my main interest is working with older people. And prior to working here in a university setting, I worked in the UK, working in a mental health team for people with older adults with mental health problems such as depression and anxiety, but also a large amount of my time was working with people with diagnoses of dementia and their families. And this is an area about which I'm very passionate and have tried to sort of build an increasing interest in JCU for my own research purposes since I've joined about 15, 16 months ago. So clinically I'm very passionate about this area and feel I have quite a lot of experience of working with people with dementia from the very early stages regarding issues of diagnosis right through to later stages where people are living in care home settings or residential homes and are often exhibiting some quite challenging behaviour. And in many ways that's one of the areas that I'm most passionate about. For some reason I find myself quite drawn to many of these people who can be quite difficult to manage but have important needs that need to be met. And that will be the topic of my main talk later. My aim for this first 10 minutes is to sort of set the scene for the talks that will come from my three colleagues, who I'll introduce in a minute, and just to give a tiny bit of background information about dementia and about carers for those who maybe join us with less experience or less knowledge. Please feel free to ask questions at any time. I'm very happy to have questions, but we also have some time at the end, 10-15 minutes, where we'll be able to answer any questions. And I'll stay behind at the end for sort of 15-20 minutes as well, where people can approach me if they like. I know there's a number of professionals in the audience, and this is a very skilled audience, so please feel free to share your opinions. And I don't come at this topic thinking that I or any of us know everything there is to know about it by any means. I think that we're all learning, so please feel free to share your thoughts. Just a little bit of housekeeping. There isn't going to be a break because we have a very packed schedule, but I guess because there's 4 people talking, hopefully it will change the pace and keep you all alert, as I know it's been a busy day for you, I'm sure. If you feel you need to go to the bathroom, as they're both outside the room, the ladies is just down the corridor there, and the gents is over the way over there. You've all been given a pack with some reading in it and some information about JCU, and there's also a feedback form in there, so it would be great if you could all fill that in at the end. Oh, and I should finally say, I guess some of the issues that we're talking about tonight could sometimes be quite distressing, and I'm aware there's people in the audience who will be living with these issues on a day-to-day basis. So I've also put in some information regarding our clinic, which is on site here, where trainee psychologists under the supervision of people like myself see people who are struggling with emotional or psychological issues. So if you feel that anything within the talk touches some personal issues for you, you could always phone and consider a referral to our clinic. So I think I've already said these are my main aims for this evening, although there are some others. But to focus on the needs of people, the needs of carers of people with dementia, and to recognise the kind of uniquely challenging role that carers find themselves in. And I think often carers are, as soon as a relative of yours becomes ill with dementia or some other diagnosis, it's almost like the carer stops being a person sometimes and starts being someone who provides services or someone who can be there for someone else. And I guess I want to really raise the idea that carers have their own needs, and it's very important that we recognise those needs and recognise them as people in their own right, which of course they are, but within my experience within services, sometimes that gets forgotten. We all hope to offer psychological ideas and perspectives that carers and professionals might find helpful when they're taking a caring role. So we want to offer you some content, hopefully, that might get you thinking about things that you could do differently or think differently or read up on when you go away from here. We hope it's a practically useful session as well as getting you thinking. And finally, I think putting my take-home message right at the beginning, I really feel it's important to focus on the importance of caring for carers. And often we ask huge amounts of carers, whether they be paid carers in nursing homes or care homes, or whether they be family carers. We expect huge amounts of them, but I think that when we're asking people to care for others, they can only care for others if they feel cared for themselves. And I want that to be a sort of take-home message, and I will talk about that a bit later on, and I'm sure some of my colleagues will also talk about the importance of recognising the needs of carers. Just to set the scene a bit, and I'm sure that very many people in the room could do a far better job than this of talking about dementia, and I don't intend to sort of talk about how diagnosis is made or the numbers of people with dementia. I just want to sort of set the scene a little bit for those who aren't exactly sure what dementia is or isn't. So it's a global term that refers to a progressive, so ongoing, not reversible decline in people's cognitive function. Cognitive function means their thinking abilities, basically, due to neurological changes, so it's due to changes that are taking place in the brain. And for the diagnosis to be made, it requires significant changes to two domains or areas of cognition. So one of the ones we always think about when we think about dementia is memory, people having changes with their memory. But that's by no means the only change that happens to people's thinking abilities. There can be changes with their language, changes with their executive function, which I'll talk about a bit later on, but basically means how they plan, how they organise, how they structure themselves, how they deal with day-to-day tasks, changes with their visual systems, so how they see and how the brain makes sense of information. These are all the sorts of changes that can accompany illnesses that come under the category of dementia. And it's very important to remember that dementia, these sorts of changes are illnesses. There's often still a very sort of hard to shift myth that I guess that as people get older, their memory significantly declines, they find things significantly more difficult. And while it's true that as people get older, there are small changes in their thinking, it is not true that there are very significant changes normally. It's when these things are occurring significantly, it isn't part of normal aging. Instead, there's something else going on, which might be dementia, might be something else, but it's not normal, that's for sure. And finally, for a diagnosis to be made, it requires that the problem that the person is having a significant impact on their activities of daily living. That just basically means the things that we need to do every day to get on with life. So that can be washing, feeding, paying bills, it could be all sorts of different things. But there needs to be an impact on the way that you're living your life. So that if there appears that there's some changes in your memory, but it's not actually affecting you in any tangible way, that doesn't really count as dementia. There's a kind of whole other series of ideas and labels that those are attributed to. But for it to be dementia, there needs to be these activities. And this is very important, of course, because this is where it has a significant effect on carers. And one of the things I've always been struck by is how, particularly in marital relationships of husbands and wives, they've often divided the roles up over the years according to what they are strong at or what they're good at. And suddenly, when one member of the partnership experiences an illness such as dementia, suddenly the other person, say the wife, ends up taking on all sorts of jobs and tasks that they've maybe never done before in their life, have no interest in doing, and don't really like doing. And I find that quite an interesting thing when I'm working with husbands and wives. So for example, there may be wives who have never paid bills before, have never dealt with the authorities, or there may be husbands who have never done the laundry or done the cooking. And actually the idea of doing that is actually quite terrifying to them, and also isn't what their sense of themselves is. And so I think that as people's activities change, what they can do changes. It brings lots of stresses to partnerships and to family networks, as people who were previously very strong at something and able at something find themselves increasingly unable to do tasks of that nature. So these are the sorts of difficulties that people can have. Memory difficulties, as I've said, language, executive difficulties. And while we think of dementia often as being all about memory difficulties, my experience suggests to me, and some of the research I'm aware of, it's not memory difficulties often that families and paid carers find difficult. What they find more difficult might be some of these executive changes, which are harder to spot sometimes and harder to measure, and professionals like myself seem to be less interested in sometimes, and these personality changes. And I think it's these sorts of things that often cause significant distress to carers, more than the memory difficulties, which is often what professionals seem to be quite interested in. They ask questions about the person's memory, they assess the memory, but it's not necessarily those things that are the carers' key concerns, I think. So dementia is becoming an increasing problem, both globally and in Singapore. And again, I don't tend to go into this very much, but there's one very obvious reason why that is. Age is the #1 risk factor for dementia. There are huge numbers of risk factors for dementia, and lots of very clever statisticians spend huge amounts of time trying to decide what they are and what they aren't, and that's useful. But the #1 by doubt is age. If you get older, as you get older, you're more likely to have dementia. So as we're all living older as a society, clearly there's going to be more cases of dementia. So these are some Singapore figures here of the number of people in the over 65s and the percentage of the population, which you can see by 2030 there'll be nearly 20% of the population will be over 65. And as you can see here, this is the idea of the risk factors. The age is the #1 risk factor. So beneath the age of 60, there are some people with dementia, not a large percentage of the population. But as you get to people below the age of 75, you're talking 14% of the population. As you get to about 85, so I don't have the numbers for Singapore, but in the UK, we're talking about 25% of the population will have a diagnosis of dementia. So this is effectively what this means. The number of new cases of dementia diagnosed each year. This is the actual figure for 2005 here, and this is the projected figure for 2050. So I think, you know, the graph is clearly obvious that there's going to be really an explosion of the number of people who have a diagnosis of dementia. And I think that internationally, this problem is being increasingly recognised with increasing amount of research into treatments for dementia, but also into prevention of dementia and how to manage people that have dementia. Impacted by this diagnosis of dementia. And they are part of a system, and we should be interested in that system, who is around them. And in fact, friends and family know the person best, and often have the best, not always, but often have the best relationships with the person with dementia. So while professionals may increasingly start trying to take decisions on behalf of the person with dementia, really it's families that know the person best and are most likely to be able to articulate the person's needs, the person's preference, and to stand up for the person's position. And I think this is very important. Certainly within the UK, friends and families, particularly families, will quite often stand up for the patient's rights. And that can cause difficulties for services, such as hospitals or care homes. But actually, it's often very useful to listen to the families and the friends and hear what they're saying and really take on board their views. And normally it comes from a genuine position of wanting the best for their relative. When we're talking about this huge increase in the numbers of people with dementia, society is never really going to be able to fund or meet all these needs. And therefore, society does place a burden on families to look after their loved ones. There is a sort of inherent idea within society that families should stick together in hard times, should look after each other in illness, and that's appropriate. But that does, of course, place the burden of that onto carers. And I was thinking about that burden as, I guess, as psychologists, I'm very interested in emotional factors and psychological factors. But naturally, of course, there's also economic factors. Actually, there's an economic cost to being a carer. And in terms of resources, what you can do, how you can get on with your life, etc. and so on. All of these are things which society implicitly burdens carers with when they label themselves as a carer and they look after someone else, which is a great role. And so within all of this, the carer's needs are often forgotten. And I think that that's one of my key messages tonight, that I'm trying to raise the awareness of carers. So to meet the needs of people with dementia, we clearly need to educate, inform, and most of all, care for carers, as I'll talk some more about. But we also need to see carers as people in their own right, with their own strengths and their own needs, with their own hopes and their own frustrations. And it's only when we really meet them as unique individuals and respect them for the role that they're taking that we can build in the best care for them, but also for people with dementia themselves. So that's all I wanted to say, really, by way of introduction. I just want to introduce you now to my colleagues who will be presenting tonight. So first up, we're going to have Rajini here, who's going to be talking about the needs of carers. And hopefully she will, well, I'm sure she will, talk about, she will talk about some research that she's currently conducting into that towards the end of her presentation. And then after that, Joy will present on psychosocial interventions in dementia, things such as life story, reminiscence, and hopefully give you some practical things that might be useful to those of you who are in a caring role. And then she will end by talking about some research that she's doing into this area. After that, I'm afraid you've got me again. I'm going to talk about my area of particular sort of passion, which is challenging behaviour. and the role of the carer. I guess I'm particularly interested in that because challenging behaviour is something that often really gets people going. Carers find it difficult, professionals find it difficult, the person themselves finds it difficult. So it's an area of interest to me, and I will tell you about some of the research in that area and try to give you a kind of very, very basic framework that you might want to think about if you're ever dealing with these sorts of issues. And then finally, Dr. Li-Ling, who's a psychiatrist from Changi General Hospital, will finish off talking about local services that are available for people with dementia and their families. And I've asked her to offer some thoughts on what we say as well, if you have, how you can contextualise what we're saying within your knowledge of the services that are out there.
No pressure. No pressure.
So it's going to be, I guess it's a bit of a whistle-stop tour, and none of us, I'm sure we could all do far, far longer on these topics, but we want to offer you a flavour of something that will be useful. But as I say, please feel free to take part and ask questions as you go. Okay, with that I will finish and hand over to Regina.
Hi everyone, thanks for coming tonight. So, well, clearly I don't have the height advantage of the previous speaker, but I'm wondering if I'm using the acoustics of the room well enough. Can people at the back hear me? All right, thank you. So I might just get going. So that's me, Rajini, and I will be talking tonight about the needs and concerns that might be quite common amongst dementia caregivers. Okay? And I thought we might start with a little bit of a quote that I found from this American motivational speaker and author. His name is Jim Rohn. And what he said was that one person caring about another represents life's greatest value. And the reason I chose this quote was because I think it really encompasses how important it is to have caregivers and the value that they add to our lives. So some of the objectives that I thought I might cover this evening, because I realized we have got quite a varied group, is that generally to raise the awareness of caregivers' needs, right? To increase understanding of the why, some of the mechanisms that happens behind the scenes that might not obviously be always obvious, as well as to normalize some of the difficulties as well. Okay, so who is the caregiver and what does he or she do? The caregiver, as Paul has mentioned, is in charge of a number of different tasks of helping the dementia patient with a number of day-to-day activities, including instrumental tasks. So when we say instrumental tasks, we talk about things like doing things for them, say providing transportation, helping them out when they need to go and see a doctor, taking on some advocacy roles as well, right? Providing personal tasks as well, so helping with bathing, helping with duties in terms of toileting, feeding, dressing and all that, as well as providing some ongoing supervision when we see, especially when there starts to be some increase in difficulties, the task of supervision tends to grow with that. Okay, so those are some of the things that I'm hoping would be of benefit tonight. Okay, so why talk about caregivers? What is the importance of addressing caregivers' needs? Anyone? Okay, basically we talk about caregivers' needs because it's largely a role that is under-recognized, in fact, right? Okay. In fact, it's the duration of the role itself that adds a lot to the caregiving duties. They did a study and they found that with people over the age of about 50, when they had this group of people that they surveyed or whatever they did, and they found that up to 50% of these people estimated their caregiving role will last about 2 years, but they were way short of the truth. Because what actually happens is that the caregiving role tends to last about 8 years. And as a matter of fact, up to a third of these group people the caregiving role lasts above 10 years. So you can see there's a long drain on the caregiver. Okay? And also compared to other types of caregivers, people who have family members who have cancer, or whose family members have other kinds of physical disabilities, dementia caregivers tend to be under added pressure. Okay? And compared to non-caregivers, when they did a sort of a matched sample, they found that dementia caregivers had a higher mortality rate by far, about 63%. So this is an extremely important population that we should not forget about. So these are some of the needs that caregivers have. Of course, need for social support, need for the intervention that is targeted at their specific needs, okay, and not just completely missing the point as we can sometimes do. need for information. But the tricky thing about dementia caregivers is that although they need information to get through their daily lives, often they don't understand enough about their own roles to be able to ask you what it is that they actually need. Okay, so especially for service providers, clinicians, medical health professional, nurses, social workers, it's very important that we understand some of these mechanisms before we move forward. So everyone is different, right? Everyone has their own needs, their own vulnerabilities. There are specific demographics that make us particularly vulnerable to caregiving stress. Okay? So for instance, spouses tend to be worse off than children when it comes to being vulnerable. So if it's your spouse that is the dementia patient, you tend to be worse off than if it's your parent who's the patient. Age, people who are older also tend to have a harder time than people who are younger. Okay, gender, unfortunately, the ladies have it worse. Okay, ladies tend to be more distressed or suffer more from the fallouts of distress and caregiving. Social isolation, so there can be environmental causes as to why we are isolated. Okay, sometimes with society, there can be some stigma with regards to aging. There can be a lack of information, or because we are so busy in our day-to-day duties, we tend to withdraw ourselves from our social environments. If caregivers' own poor health tends to be a bad sign for their well-being. Okay, poor coping mechanisms, as well as culture. Ironically, in the Asian culture, because we tend to be very Confucian, we have this idea that we need to be filial to our family members. Asians tend to find more meaning in their caregiving duties, and because there is this meaning, they tend to do better in terms of risk as well. Okay. There are certain care recipient characteristics that make us vulnerable as well. So behavior difficulties or behavioral challenges in the care recipient can make things more difficult. Incontinence is a particular one, as well as a physical disability on top of the mental difficulties and the behavioral difficulties that we might see. Okay, so role. So the caregiving role, we talk about it as a role, right? As an Indian daughter, as a Chinese son, there's a certain role that we all are expected to fulfill. And these roles are very strongly imposed on us through society, through the things that we are taught as we are growing up. But unfortunately, when things go well, no one says, hey, good job, and no one gives you a pat on your back. Those things are sort of unrecognized. It's only when things go badly that people recognize it, right? Okay, so that's quite an unfortunate thing. And role stress is manifested in many different ways for the caregiver. So we talk about role conflict. So having too many things to do, too much role overload. Okay? Role captivity, the sense that you're trapped in this caregiving role that there is no escape from. Ambiguity, not really knowing what you're supposed to do. And transition. So as the dementia patient progresses through life and through their own stages, we too as people tend to transition through our own different phases. So as a daughter, you might then become a mother as well, and you have your own changes and your own demands. So role transition can also be very difficult. Okay, anxiety. Now, caregiving and anxiety, one of the main things is that the literature tells us is that caregiving is the most common anxiety inducer in our relationships. So when it comes to marital relationships, when it comes to intergenerational parent-child relationships, the anxiety often comes from the caregiving role. Okay? So when we talk about carers, we talk about the two types of carers commonly, right? Usually you have child carers and spouse carers, most commonly. Child carers, of course, there are more child carers than spousal carers. Okay? For the child, anxiety comes from what we term filial anxiety, and this can come from two separate sources. One is the notion of coping. How well is the person coping with the stresses, with the idea of the parental decline? Okay? So the parental decline itself can be a very stressful thing for a child to have to watch. Right? When the child sees that, the next step is also the perception. The perception of whether this is a positive situation or a negative situation. Okay? If I perceive this to be a negative situation that has been enforced on me, it's infringing on my other roles in life, and I'm confined to this role, I'm likely to become angry, and because of that, I'm likely to become guilty as well. Okay? Because as a child, I'm not supposed to feel this way, right? Okay? So guilt, the problem with guilt is that it can become very toxic. Okay? I remember this one client who had presented because her mother had passed on, and she was having troubles with her bereavement. Okay, she could not get out of that grief cycle, and this had become quite chronic and very sort of stuck, and there was nowhere she could go. And as I talked to her, I realized that the guilt that she felt was not just surrounding the situation of her mother's death and the things that she did and the things that she didn't do, but there was also guilt from way back when, from when her mother was first diagnosed with dementia, and she had those challenging behaviors that she couldn't understand why, and she felt that she should have been more compassionate, more understanding, more caring, and that guilt became so toxic that she carries it until now. Okay, so that's why guilt is a very dangerous situation dangerous thing for anyone. Okay? So all these situations, the anger, the guilt, all lead to depression and anxiety. Right? So that is for the child. So for the child, caregiving comes at a great psychological price. Now, since my own mother is in the room, I think I should stop talking about child. And I shall talk a bit more about the spousal carer. Okay, so for the spousal carer, this is also a very difficult situation. Why? Because this is someone that has been by your side for decades and decades. Okay, they are your companion, your source of support. You've made plans together. Oh, we're going to retire, we're going to travel the world, and suddenly all of that is gone. Okay, and that's where the spousal anxiety comes from. All right. So next, more cheerfully, depression. Okay. So now, depression is also really serious. Why? Because a third of all caregivers at some point will have a depressive episode in their